Welcome, everyone. So glad to get started. So glad for you all to join our March monthly meeting and our Friday facts. We have a great theme. This month is all about palliative care. Well, many of our months are all about palliative care, but I am super excited to have our meeting focus on two people and organizations that I think will go really well together. As always, we start with Friday Facts, where you get to know new members and new people doing really interesting work and important work around North Carolina. And my new best friend on email, and this is the first time we're meeting, another Heather. So there's a whole group of Heathers that are part of the North Carolina Serious Illness Coalition. And so another Heather B, Heather Burkhart might be joining us from ARP. But Heather Boykin reached out to me a few months ago, and we started talking. I'm doing double duty and also including other people, letting them in, about issues around palliative care and how we can do more in the palliative care space in North Carolina, and ironically, how to address some of the things that came out in the CAPC scorecard, which Stacy Sinclair is going to talk about afterwards. So take a moment, introduce yourselves on the chat line for those. We're going to do a few multitasking. Introduce yourselves on the chat line as people come in. But I'm really excited. This is my first time I get to see her on screen, but I love her passion and invited her to join Friday Facts to talk a little bit about herself, her work. Heather Boykin has all kinds of initials, nurse practitioner. Yeah, you do. You have a lot of and you can explain all of them, but she is the director of community-based palliative care medicine for Lower Cape Fear LifeCare. Some of you have met Jason Clam, who has joined also. So I'm really excited to have Lower Cape Fear LifeCare as part of the coalition. And so I would like to turn it over to Heather so she can do a few things. And I know she has slides, but share about yourself, your background, and also what Lower Cape Fear Life Care is and your passion around palliative care. Because I say all that because I know she has slides. So rather than
Yeah.
we'll still jump in with questions, but I'm going to let her take it away because so excited to have you and what I know is your advocacy and passion.
Thank you so much, Heather, and also to the cohort for allowing me to have a bit of your time and attention today on such an incredibly important topic. And I know a topic that's very near and dear to all of you. Before I introduce a little bit about myself, I also wanted to let you all know that our CMO from Lower Cape Fear Life Care and my esteemed colleague, Dr. Derek Weiss, has also joined us today. So certainly he'll jump in and enhance anything that I present to you today. I do have, a quick few slides just to show a few things to you about our organization, and I'm hoping that will go off without any issues with the text. So let me see here if this will work well. How does that appear to you all?
Great. You can just click the slideshow and then.
Wonderful.
Perfect.
Great. And I can still see all of you, and you should be able to see my introduction slide. Wonderful. That gives me some comfort. Okay. Well, again, thank you so much. As you heard, my name is Heather Boykin. I'm a nurse practitioner. Been doing palliative care for about 10 years now. A little bit of background about why am I in palliative care at this point. I worked in the care of people with chronic and end-stage renal disease, and I did that work for many years right out of nurse practitioner school. And what I realized from the honor of serving those patients and their families is that we as a nephrology community and a medical and nursing community, we're leaving a lot to be desired when it comes to taking care of the whole person on the journey of serious illness. I witnessed a lot of people on their trajectory of kidney disease and dialysis having very little support in the way of decision-making junctures, people that were interested in understanding their illness representation and helping guide them through navigating quality of life and decision-making with regard to their medical care in a way that aligned with their goals, if that makes sense. So I promised every single one of those people as I departed nephrology and headed towards palliative medicine that I would never stop working for them and to enhance the support that they need to be successful in their journeys and to be able to protect and preserve quality of life all along the way. So that's why I'm here in palliative care. I come from academic medical center. I have to give a lot of props to UNC, and I see some of my colleagues on the call today. I joined Lower Cape Fear LifeCare almost 2 years ago. Will be an anniversary in October as a manager and now director of community-based palliative care. So I want to tell you a little bit about what we're doing here in Southeastern North Carolina, because I would imagine we're taking care of either your families, your patients, your friends. And so I want to let you know about this important resources that is here in Southeastern North Carolina. We are Lower Cape Fear LifeCare, and the good news is that in October of this last year, we opened the Center for Palliative Medicine, which includes a pretty unique first standalone palliative care clinic in Southeastern North Carolina. So that clinic stands alone outside of a hospital. It frees patients up from getting a costlier hospital-based clinic copay, but it's everything palliative care. So it's multidisciplinary where patients and families come in for all the comprehensive, robust support that they need to navigate their journey of serious illness, whether that's social work support, chaplain support, nurse practitioners and physicians providing high quality goals of care, decision-making, advanced care planning, discussion, but also really comprehensive symptom management to help them, to help relieve their suffering and the stressors of their illness. So we have an incredible resource there. We span several counties, as you can see. I'm hoping my slides align with territories. Hopefully you all are seeing that well. We are across the counties that you see here. We have inpatient programs that you will see listed: Novant New Hanover, Novant Brunswick Medical Center, Columbus Regional Healthcare System, our inpatient programs. And then outpatient, we have the Shipyard freestanding clinic that I was just mentioning, and also some partnership embedded clinics with Wilmington Health, which is a large local physician-owned organization. And then, of course, we go to patients as well. So we provide very comprehensive home-based palliative care services in all of the counties that you see there. So no matter where patients are located in the hospital, able to travel to clinic, or are needing more home-based care, we can provide that quality palliative care in their homes. We also have a really incredible line to the care that we offer here at Lower Cape Fear LifeCare, and it is an enhanced program for patients and families that are living with dementia, and that's our LifeCare Memory Partners program. It is also aligned with the CMS guide model, if any of you are familiar with that. I won't get into the specifics of that today, but that is an additional enhancement to the Memory Partners program, which provides robust social work, nurse practitioner, nurse navigator, and care navigators, providing all kinds of support to patients and families navigating the complicated journey of dementia. So I hope what you're gathering about LifeCare is that we have robust palliative care services across many venues of care. We also are a unique partner for patients navigating the journey with dementia. And then, of course, LifeCare also has a hospice foundation as well. So we have care centers across Southeastern state and a very robust hospice, not-for-profit hospice program. So that's a bit of our organization, myself, and of course, Dr. Weiss is here as well for any additional questions. Another piece to wanting to have a little bit of your time today is that, as you will see when we get to review the serious illness scorecard today from CAPC, that there, very unfortunately, is no palliative care advisory council in our state. I had to read that a couple times to make sure I wasn't reading it wrong when I saw the serious illness scorecard. So, of course, like many of you, I became very worried about how our lawmakers are navigating decision-making and legislation without this resource. to speak specifically to what is palliative care and how do we provide this direct support to patients in their homes to navigate the serious illness journey. So we need to get this started, and it should have probably happened many, many, many years ago, but there's no time like the present. So I'm hoping as a partnership with this coalition and all the very valuable connections that you all have, that we really may be able to join together in a multidisciplinary, diverse way and form a council that we could ultimately be recognized by the state as a formal advisory council. The way I envision this is very much like a lot of the palliative care advisory task forces and councils that you'll see listed in the serious illness scorecard that are everywhere else except for North Carolina almost. And this would be providing consult and advice to agencies like Department of Health and Human Services, our governor, and of course, other esteemed General Assembly members on all matters of palliative care, on all matters of serious illness, giving them education on our specialty and how it uniquely serves the community, as well as the current needs in our state with regard to palliative care and initiatives that are underway to expand care. Other ways that I think that Palliative Care Advisory Council could be helpful is to examine palliative care services across the state so we can get an idea of what is already happening, where needs are being met, and of course where needs need to develop, and be able to develop our own recommendations for resources across the state. So again, this would be richly multidisciplinary, very diverse council from venues across the state, clinical and non-clinical people, of course, with the ultimate goal to expand and improve access to high quality palliative care for all North Carolinians living with serious illness and their families, regardless also of their status with insurance, their status with their status with residency or whatever. So this should be, my point being, this should be care that any person with serious illness should be able to access and easily access for support. So I'm really hoping and really kind of begging that we all can come together to get some momentum going beyond this slide and this idea, to get the legislators' attention and see if we can partner with them to help them make good decisions going forward. And I think that kind of wraps for me. I hope it might be okay for Dr. Weiss to just enhance that or add anything additional, and certainly would love to hear from the group.
I don't think I do, Heather. You rocked it. I just would like to put in 2 cents for forming this council, though, and it would be great if we could somehow partner with the North Carolina Serious Illness Coalition to help us kind of get that going. Yeah, it is kind of shocking that we don't have that here. I moved here about 5 years ago from Montana, and even Montana had one, even though I was one of 5 board certified palliative care doctors in the state. So we've got a lot more than that here. That's all I have.
Well, I'm so glad that you both joined us. Thank you, Dr. Weiss. Thank you, Heather B. And if you can speak a little bit more, because I know that your motivation, your passion, and your leadership has gone beyond what we see on those slides, because you have already gathered or have started to identify, I know this because we've been emailing, a group of people that have a shared focus on this. Do you want to talk a little bit about some of the, feel free to name drop, some of the others that you have found around the state that are interested in this? Because I think that'd be helpful for the other groups, other people here who actually represent other health systems, because I'm looking at the names. I see Novant, I see UNC covered, I know ECU. So you've got a neat group. Oh, you have A&T here. So you've got a nice group here.
Absolutely. And I will say this because I don't want anyone to feel like in this initial survey there's been any exclusions. I have simply kind of tried to talk with my connections and my small network group to see who's interested. So I feel like this group could be very large, as it should necessarily be. But I see Dr. Catherine Aragon is on the call. Also a very esteemed colleague from UNC healthcare system. She is a mentor and a leader in her field and in palliative care, and has also expressed incredible interest in getting the Palliative Care Advisory Council built and moving forward. Also, Candace Kastner is the director of inpatient palliative care at UNC Chapel Hill, is a physician assistant. Dr. Chris Jones from Duke has also, of course, expressed very intense interest in this initiative and being part of it. Of course, myself, and Dr. Weiss, and a number of other people from our organization. I also have heard incredible interest from Duke social workers and UNC social work colleagues about wanting to be involved. So certainly from the academic medical centers, again, in my kind of small field of vision, have already expressed incredible interest. And I have no doubt there's many others that want to be on board as well.
I know I am not the only one that's going through my Rolodex in my head right now of let's get this person, and let's get this person, let's get this person, and I'm sure that is marinating with others. My wonderful colleague Ellie Ward and we were just on another conversation right before this meeting about serious illness conversation training, and so Ellie put out a question or an pondering, and I want to have you see that in the chat. And Ellie put, might there be a possibility of creating a palliative care council that also helps advocate for specific palliative care focused work that's not just for palliative care, which we keep trying to promote, like serious illness communication skills?
And I am on audio, but my video is again malfunctioning. So I'm sorry, you all, but I'm happy to engage in this conversation. What are your thoughts, Heather?
Yes, absolutely, 100% a yes all the time. And I think, you know, the other leaders that, I've worked with before in our fellowship programs at UNC and also at Duke, who do a lot of teaching in serious illness communication and also have very incredible resources that they use for their fellowships. I know that those leaders also would be very interested in this aspect of the Palliative Care Advisory Council, because the specialty of palliative medicine, our duty is, you know, obviously primarily to the patients and families that we care for, but we also care for our colleagues who are taking care of people outside of the palliative care specialty. So teaching them how to have serious illness communication, whether it's clinical people, whether it's lay people in the community, from faith organizations or other places of support that patients seek, to talk about serious illness and help them navigate that journey with support. So yes, absolutely. I think there is certainly a big education piece to the Palliative Care Advisory Council beyond the legislative focus. If that makes sense and answers your question, hopefully.
It does. And I, I'm fond of saying this, that, when you think about the number of hospitals or health systems across North Carolina, across our country, that claim that they are providing patient or person-centered care, but then we're not having goals of care conversations with those patients or those family members. So how can that be a thing? How can we possibly be providing person-centered care if we don't know what's important to the person?
Mm-hmm.
So anyway, I know I'm singing to the choir with that.
Mm-hmm.
Absolutely. Well, I think, and also we, as an advisory council, could also encourage fellowship and medical programs and nursing programs across the state to have curriculum that is specifically focused on educating these young clinicians and non-clinicians who are going to eventually touch patients and families, how to do this work, how to have serious illness conversations. We often find that we're kind of working against ourselves, doing that education late when residents are already out practicing, when nurse practitioners and others are already entered the field. But if we can advocate for building this into curriculums across the state at all of the great universities that we have, we would really be ahead of the game.
No doubt. And, supporting an interdisciplinary approach to these conversations. So it's not just the physician or the provider that's leading the conversation, but you've got all these other, really skilled and talented people that are bringing different approaches to that conversation, so that that patient and their family are really well supported holistically, not just what's happening to them medically, but psychosocially, spiritually, emotionally, relationally, all of that. Love it. Let's do it.
So one of the interesting things about having Heather present now and going first is it's like a phenomenal appetizer kickoff for the conversation that we're going to have in the presentation from Stacy Sinclair about the scorecard. And I'm blurring the boundaries of our different agenda sections because my question, and I know the answer a little bit, which is why I want to push it a little bit more, is about, and we'll talk about this more in the next section, but we can create an advisory council in the sense that we can create with the serious illness. We're great at creating task forces and councils and collaboratives, and you're getting this amazing response. And as you said, you've identified folks. We can bring in lots of other folks, and so we can create a collaborative. We're good at that. We've done that around caregiving issues. We've done that now around advanced care planning educators. What I don't love, and Stacy knows this because she presented to the South Carolina group, is that the council, in order for it to be counted, has to be legislatively created and blessed. And Stacy, I know we're taking a little moment from what you're going to present on, but feel free to jump in there because I would like to professionally whine about that. Why? Because that is a different hurdle that we have here. Why can't we just call it? Why does it have to be through a legislative channel to get recognized? Because we'll do
Yeah.
this anyway. I already feel really good. I can tell there's energy. We can do this, but you may not bless it.
Right. Well, okay.
You'll
So
bless
it's
it, but
Heather, it's a great question because I do think and I'll talk about this more when I go through the presentation is that we were also trying as we were developing the new methodology for the report card, we were trying to find ways to recognize efforts and activities that states have done. So some states have these legislatively established advisory councils. Some states have incredibly powerful and effective coalitions. And so we wanted to make sure that that was incorporated so that, you know, if you had one or the other, you got credit. And we can talk about the importance of that or not importance of that, depending. The thing that we see that can differentiate these legislatively established advisory councils is then the fact that that body is embedded into the infrastructure of the state policymaking apparatus. And so that is that the legislators have been educated on what is palliative care and how it can contribute to their goals. Depending on how the legislation is written, they may expect a report from the council about recommendations. And so they're expecting that to come across their desk, which means that there's a greater chance that they will read it. And I can say that some councils do require that report, some councils don't. We can get into the nitty-gritty of that. Also, depending on how the council is structured, then usually it is embedded within the State Department of Health or similar organization, and then has in-kind staff support to advance the priorities of the council, or at the minimum provide some infrastructure to carry out the efforts. Again, depending on where the council is situated and then how bought in those state officials are, how well connected they are, sometimes it can be incredibly effective because they're learning about palliative care and then where that could be incorporated into other initiatives. So in Alabama, I sat in on a meeting of their advisory council where a representative from the state prescription drug management program was at the table and was listening to an issue around opioid prescribing at the time and said, this is a tweak that we can make to the PDMP to support prescribing. And that happened because that person was at the table. Similarly, in Texas, there is a lot of work to incorporate palliative care into value-based payment because the person at the State Department of Health, who is the intermediary for the council, is also working in the Medicaid value-based payment department. And so it is this embeddedness that comes through the legislation that in our in our view, differentiated it a little bit from the councils or the collaboratives or the coalitions, which are also incredibly effective. And I really don't want to undersell that point. But it ends up being that both and. So that's why we look at them a little bit differently, not one better or worse than the other, but to say that these can mutually support each other. I hope that helps.
It does, and I won't prolong my whining. I will have things to say, but I see my wonderful colleague Marissette has a question for either Stacy or Heather.
Yes, just a comment. Thank you, Stacy, and thank you, Heather, for what you shared. Absolutely, North Carolina should have a palliative care state-supported advisory council. I would like to reference also Virginia, and Stacy, you know the work that they've done there legislatively. Their legislative body put together a framework for a palliative care advisory council and put monies in their budget to allow for them to do a scale or to do a review of palliative care services in the state and to look at what could be done differently. And so that also helps because funding, of course, to have people to do it, all of that kind of stuff, to do sort of a survey of the state, which is something, of course, that, you know, Heather mentioned. So that's the other piece of this too, that when the state gets behind it, there can be some budgetary dollars put behind it as well for the work. So just wanted to share. One of my colleagues is involved with the Virginia Palliative Care Advisory Council over there. That's just getting started, but they've gotten some great momentum, particularly with their survey.
Well, and to continue this, because I just think, you know what, I think this is the part, rather than talking about it later, this is where we're having the richness of the conversation. And Lee Dobson, I don't know if you're able to chime in here, because what I have heard is that in North Carolina, there is not a big appetite among our legislature for study commissions, task forces, advisory councils. Part of our North Carolina Institute of Medicine report that helped to start the North Carolina Serious Illness Coalition back in 2020 had and then that there was a big blessing to do that report, talked about issues around creating a caregiving task force that would be legislatively appointed or blessed, or however the right language. And so there was a meeting of a number of health groups, I think now 2 years ago, when that was first brought to me, that probably wasn't going to happen because our legislature doesn't like to do these things. And so that's why, Lee, I hope it's okay. She and Mary Bethel, Mary's not able to be with us today, but Lee, and apologies, and Mike Kondratik are really our link into the advocacy and legislative space about what is feasible. So Lee or Mike, if feel free to disagree with what I'm saying or kind of help us understand what is actually possible with our legislature.
Well, I guess I will jump in, and then Mike, you can jump in as well. Heather, you're correct that our North Carolina General Assembly does not want to create any additional commissions, study commissions or anything. They'd rather work within the established standing committees to do any of the work that needs to get done. As to why, I don't know. That's just the way they want to work. Mike, you may have, more insight on that. But we're working within the environment in which we are operating.
Yeah, I think that's right. I guess the only thing I would add, Lee, I don't know if you'd agree with this, but it also it also generally seems to, you reach out to legislators who have a particular connection to an issue, and if they really want to see something happen, if it's the right legislator with the right connections, the prevailing preferences for how issues get handled then also get tossed aside pretty quickly. So that's the only thing I would add. I think Lee's right in terms of the general feeling, but I also think putting the effort in to have the conversations just to see how legislators, particularly the well-placed legislators, so read that to be Republicans here in North Carolina, on the committees that handle this or that oversee this issue, just see how they react, and then start to kind of move from there based on what they say.
Mhm. Well, my mind's going, and I'm sure a lot of you are thinking through and strategizing. Maybe the way to close this out is to ask, and Heather B. Well, clearly it's not this Heather. Let me know if this would be helpful. But what I think might be interesting is for those folks who would like to, regardless of whether we get a check mark on the CAPC scorecard, which we want. Some of us are driven by, and Marissette and we had a conversation Wednesday with the South Carolina. They're like, we want a better score. Like we're like, sure, we want the score we want a better score, but we also want the score to reflect the actions, appropriately reflect the actions that we're taking. But maybe the way to close out this part is to see, are there others that are motivated by this? And regardless of the scoring, could we create a specific focus, as Heather discussed, around the Palliative Care Advisory Council? We can name it whatever we want. But I think, Heather, if that would be helpful, so that way other conversations that are happening, you either can put in the chat line or you can email me and I can connect you with Heather Boykin. But that way we can start to have that group of us meet. So just like we have done with the Caregiving Collaborative, just like we're doing with the ACP educators. And I do think, and Ellie, I love the just like we're doing with the serious illness communication training, where I think there might be some very strategic partnerships that could happen, which I'll just say potentially we could go to the legislators. I talked to one last week about the idea of having a caregiving caucus. Maybe there's a serious illness caucus that in a way gets to this, where we have a few issues. So if so feel free to put in the chat or feel free to email and I'll connect you with Heather. I told Heather we want to be as supportive as we can through the Serious Illness Coalition. We have questionable capacity, but I know that with her leadership, happy to help on the sort of administrative end of, helping to share things with all of you and post things. So any last questions of Heather, or ideas, insights, motivations?
I will say, while you're thinking of last minute questions or anything, an opportunity that I do have on April 22nd, coming up pretty soon, is a day at the legislature. So I do hope to have the ear of a few that may be traveling across my path that day. And I would love to be able to share, a 5-second or even a 5-minute little elevator speech with them about what we're planning to do, but also give them a great idea about all the faces and people and places that are coming together to put momentum behind this coalition or advisory council or what have you. So the more I know about how this looks and who wants to be involved, I think the more I can certainly share that exciting news with anyone who will listen to me on April 22nd.
And when I hear the number April, or the date April 22nd, it makes me think that a meeting of like-minded colleagues, advocates, professionals, advocates should happen before the 22nd. So that way we can help provide some feedback. So I love dates to help motivate action. So we are going to move forward to be supportive how we can. Heather, thank you so much. And if Dr. Weiss is still on, oh yeah, there you are. Really excited to have Lower Cape Fear LifeCare with us, and a shout out, also another grantee with the License to Give Trust Fund Commission. You're doing some work, if I'm not mistaken, because that happened about 2 meetings ago, and I did a shout out. And so we are now playing together in a number of different circles, and just really happy to have you as colleagues and friends. So thank you.